To the 120th session of the Weekly Huddle. I'm your host, Anoop, and joining me today is my friend and co-host, Praneeth. We both are cardiologists working at KIMS Hospital. As most of you know, that the Huddle is an unscripted audience-level interaction where we try to address common clinical scenarios that we encounter in our clinical practice. Last month, we took a 6 weeks break where we tried to reorganize ourselves with an attempt that we can probably make the Huddle discussion a little bit more meaningful to our attendees. And in doing so, a slight change in formatting that we have done, where we are trying to include one or two presentation or some kind of flow chart, and we are trying to involve more expert opinion in our discussion. So keeping that theme in mind, today our topic is very basic, something that we take it for granted, and that is taking care of diabetes patients. And in today's discussion, I'm trying to address everything about diabetes, but not sugar control. So we'll not talk about sugar control today. We'll talk about everything else that we should be doing in terms of a comprehensive care for diabetes patient. And since I'm not talking about sugar, I on purpose omitted the dietetics part of it, partly also because dietetics in diabetes can itself be one particular session. So I did not think I would do justice by spending 5-7 minutes talking about diet in diabetes. So in today's discussion, I have invited, and hopefully at some point I will have my panel of experts sharing their thought about diabetes care in their particular specialty. We will have a representation from endocrinology, obviously, but we will also be listening from nephrologist, dental, neurologist, ophthalmologist, internal medicine, and cardiology. We'll try to see how a comprehensive care can be done. And I'll try to be as brief as possible. And I would request my experts to be also as brief as possible, maybe 4 or 5 minutes for each of these, so that in the last we will have about 15-20 minutes for an open discussion. So the case which I'm going to discuss today is a 55-year-old female. She has diabetes for about 7 years. She does not have any other comorbidities. She had been following with an outside doctor, and now she comes to me for establishing care. So she's essentially seeing me for the first time. She does not endorse any particular symptoms. She saw her doctor last about 2 years back, and after that, she has not seen any of the doctors ever since. But she had been quite religiously taking her medications and doing what she thinks is appropriate for diabetes care. On my review of systems, there were few symptoms that I could elicit. She did say that her feet feel numb once a while, although she has never experienced any injuries or anything, and she has never sought any help for that. She does have some epigastric fullness and discomfort, particularly postprandial, which she attributes it to gastritis or dyspepsia. She does get occasional headaches, which she has very poor characterization, and occasional back pain, which again she attributes to poor posturing. She's a housewife, she's non-vegetarian, reasonably active, and a non-smoker. Her basic cardiovascular exam is within normal limits. She came to me with a panel of master health checkup. I won't tell you the individual details unless you ask me to. Her labs, which included hemogram, renal profile, thyroid profile, they were all normal. Relevant for today's discussion, her HbA1c was 7.1. And amongst lipids, her LDL was 96. I have other reports with me also, which if you like, I can share it with you. Her ECG and echocardiogram, which were part of the master health checkup, were reported normal as well. Amongst the medication, I'm telling you the daily dosing, not the divided dosing. She takes 2 grams of metformin daily, 5 milligrams of linagliptin daily, 25 milligrams of empagliflozin, glimepiride 2 milligrams, and 1 multivitamin. That is her entire medication list. Once a while, she takes pantoprazole if she has any dyspepsia symptoms. So I will start today's discussion with endocrinologist who is on the panel today. So Brinda, question for you. This patient, if comes to you, you have got an A1C of 7.1, you have got some of these medications. As I said, we will try to restrict our discussion anything but sugar control. So tell me, other than sugar control, how do you see this patient? What all you are going to discuss about this, and then whichever organ system you want to address in this patient, I believe I will have an expert for that organ system in today's discussion, so we can take opinion from that particular expertise. We can go one by one. So Brinda, please go ahead. And I will be sharing the slide that you have shared with me so that people can read through your mind as you are talking. Brinda, all yours.
Good evening, everyone. Seems like, this patient has not seen a doctor for almost 2 years now. So I think this is a very appropriate time to, address her diabetes and beyond just blood sugar control as for the topic today. So I think, goes beyond saying that diabetes is not just about sugar control. It's about, monitoring and managing complications along with it. So, the gist of it is that, of course, it's very, very important. The concept of screening is essentially to, pick up any, complications in the beginning as at an early stage so that you could intervene early. So for this patient, starting with, as I mentioned on the slide too, she definitely, I would recommend going for a dilated eye examination. She needs to be evaluated for retinopathy. So a referral to an ophthalmologist would be recommended for her. And then this patient actually did complain of some, I think some feet neuropathy-like complaints.
I will interrupt you for a second. So can you just give me a little bit of idea about, let us talk for the next 5-7 minutes about eye exam. What do you exactly mean? How do you counsel the patient? And then I will have Dr. Prithu Vyas, who is an ophthalmologist, give his opinion about what he will do when the patient reaches him for diabetes assessment. So Vrinda, just give us 1 minute gist of how you refer these patients for ophthalmology evaluation.
So I do tell the patients, I do counsel the patients that, with diabetes, it could potentially affect the eyes. So, patients with diabetes are at risk of developing retinopathy, glaucoma, cataracts, and, refractive errors too. So based on this concern, I usually will tell them that a lot of times by the time you develop symptoms, it might be too late to go to an ophthalmologist. So the concept of screening comes. So that's when I'll ask you to go see an ophthalmologist for your complete comprehensive eye exam, including a dilated eye examination.
And is it something that you tell them at the onset of their disease, or the moment they are diagnosed with diabetes, or are there certain algorithms or checks and balances? Is it something for everybody? And how frequently? Is it annually? Is it once in 2 years? Give us some idea.
So patients with type 2 diabetes, absolutely at the time of diagnosis, I tell them it's not an emergency. If the blood sugars are very, very high, like 300s or 400s, I tell them to get the sugars under a little bit control before they go see an ophthalmologist. For type 1 diabetic patients, basically we wait out about 3 to 5 years since the onset of diabetes, and then annually thereafter for both the sets of patients, type 1 versus type 2, they need an annual eye examination. Now, a lot of times, if the patients have no evidence of retinopathy, the ophthalmologist may take a call depending on the findings, whether they want to see the patients, like, say in 1 year, or sometimes they may extend the review, say, to 2 years. But the guideline recommendation is every year, annually.
Okay, Vrinda, I'll request you to pause for a second. I will ask Dr. Prithu Vyas. Dr. Prithu, this patient, let's say, sees Vrinda and then comes to you. It has been referred to you. Please guide us through over the next few minutes. How do you see this patient, and what kind of value you can add when the patient comes to your clinic?
Okay, good evening, everybody. This is Dr. Prithu Vyas. So as Dr. Vrinda has rightly pointed out, the first important thing when we find or diagnose a patient with diabetes, referral to ophthalmologist at the time of diagnosis is very essential, as we never know at what stage the retinopathy is. And depending on the level of care, that is, if it is a primary care, usually we go for an ophthalmoscopic examination of the retina along with a retinal photography. If it's a tertiary care, we go for a fluorescein angiogram and an OCT to clearly identify if there is any maculopathy also correlating with the diabetes. And otherwise, the protocol for diabetic patients to get ophthalmic checkup would be, as doctor has mentioned, it is definitely at diagnosis, and usually it has to be done annually. This is as per the guidelines laid down earlier. But I would definitely see into the other comorbidities. Particularly, I will check into hypercholesterolemia and hypertension also. If they are associated with diabetes in the patient, I would recommend probably an earlier follow-up. And also, I would correlate with the HbA1c levels particularly. And I particularly prefer doing earlier checkups. Suppose if the HbA1c is between 6 to 7, usually I follow the same annual protocol. However, if it is around, say, 7 to 9, I prefer to call the patient back in 6 months, even if the patient doesn't have any diabetic retinopathy, because there is a higher chances and the patient is at a higher risk to develop retinopathy earlier. And if the patient has higher HbA1c levels, probably a little more earlier. And it'll also go for further evaluation of the retina. And as Dr. Vrinda has again mentioned, it's not only the retina, but diabetic patients are prone to develop cataract at an early age and also glaucoma at a very early age. So these have to be monitored, and a comprehensive eye examination has to be targeted, and it's not only the retinopathy. Yes.
Thank you so much. Thank you so much, sir. If you could stay with us for a few more minutes in case if we have any questions, we will address. Praneeth, you raise your hand. Any question that you have at this point?
I have a question to Dr. Pradhyas regarding an ophthalmology examination. I believe you are a retina specialist. Just like there are specialist cardiologists and interventional general and non-interventional cardiologists, like who are the ophthalmologists that should be referred? Do every patient need to go to a retina specialist, or a regular ophthalmologist can do the job? Understanding that if a patient is in a tier 2 or tier 3 city, then how do they need to approach? And like if a person is in tier 2 city, what is the ophthalmologist expected to do, or what are the ophthalmological services that can be expected?
Yes, Dr. Praneeth, it's like, see, you have a specialization from a general physician to a cardiologist or a nephrologist. Even we do have this specialization, but I would say a general comprehensive ophthalmologist can easily pick up the findings of diabetic retinopathy and maculopathy with a decent expertise. And even in tier 2 cities, it shouldn't be a problem whatsoever. And most of the general ophthalmologists also have fundus imaging, retinal imaging. I can say at least more than 70% of them will be having this, and they can even refer or even get a suggestion from their retina colleagues by just sending the picture of the retina. So we can get a basic assessment with this. So it's not necessary that every patient needs to go to a retina specialist because travel and there are a lot of factors which can come into play. So the best would be the nearest ophthalmologist. And in fact, nowadays, many physicians, we have actually trained many physicians and diabetologists with the basic ophthalmoscopic examination and retinal imaging also. There are non-mydriatic cameras, fundus cameras, wherein it will hardly take a minute photo. And if you can just send it through to a retina colleague, I think that makes things easier. Not considering the cost factors, of course, it's not like every time for the cost, but considering the patient's condition. So I think diabetes screening has become very easy nowadays. Even tier 1, tier 2 cities, I think it shouldn't be a problem. Particularly to a retina specialist, yes, I would suggest in case the basic examination, the basic fundus photography, if the patient, if the general ophthalmologist finds any difficulty, only then usually he refers to the retina specialist. From a non-ophthalmologist point of view, probably if the patient has an uncontrolled diabetes with a high HbA1c levels, also having neuropathy or other microvascular complications of diabetes, then it's always prudent to send directly to a retina specialist, because there are higher chances for a patient, as you all know, that a patient with a diabetic nephropathy most of the times will have diabetic retinopathy and might need some intervention. Yeah.
Pranit, I hope that answered your question.
Yes, Anoop.
Okay, Brinda, if you could move on. I think we addressed the ophthalmology part. Tell us what else you would be doing with this patient as a part of comprehensive care.
So very important would be to actually screen for diabetic nephropathy as well. So for this patient, I believe that this patient hasn't had any urine albumin or creatinine ratio checked for the labs that you mentioned, but I would say that measurement of urine albumin to creatinine ratio in a spot urine sample would be the next screening strategy for this patient to detect diabetic nephropathy. This is a single most test, which is kind of, the earliest clinical indication of, diabetic nephropathy. This is something which I would check at the time of diagnosis of type 2 diabetes. And for type 1 diabetic patients, I would defer it until, say, again, say 5 years since diagnosis for them. I'm
sorry, did you say for type 2 or type 1?
For type 1, it is 5 years after the onset of disease.
Yeah. Because I heard it the other way around, yeah.
Sorry. For type 2 diabetics, it's actually at the time of diagnosis that they should receive this screening for diabetic nephropathy with a spot urine albumin creatinine ratio. Also, an estimated GFR calculation. So these are the two things which I would request for this patient if it's not been done on the labs. And then, a lot of times, if say it's minimally elevated, the urine protein is minimally elevated, I would like to repeat it on a separate day, also making sure that, the blood sugars are not very high. Sometimes, with acute hypoglycemia, trace protein could be detected. So all of these things keeping in mind, but I would definitely send her for diabetic nephropathy screening.
So, Vrinda, follow-up question to you. I think that Rajiv sir hinted you on that. Why 3-5 years in type 1 and why at the time of diagnosis for type 2?
It's understanding basically the natural history of kind of progression of diabetes for type 2 diabetes. Almost about 50% of patients may actually be harboring these complications in the asymptomatic state for type 2 diabetic patients. Because we usually understand that, the pathogenetic changes might have started like quite a few years ago before, say, a person was diagnosed with the type 2 diabetes. So they are at a much higher chance or risk of harboring these complications from uncontrolled hyperglycemia with type 2 diabetes patients.
Thank you, Vrinda.
Yeah.
Okay. Rajiv sir, let's say this patient was to come to you. We are talking about proteinuria. I'm guessing asymptomatic because now it has been checked at the time of screening, and maybe some reduced GFR or whatnot. How do you see these patients? What kind of value do you add, and what is your frequency of follow-up for these patients? Rajiv sir.
Yeah, so actually, Dr. Brinda has made my job a little bit easier. So there has been kind of like a paradigm shift in the way we approach diabetic nephropathy. For example, we now call it diabetic kidney disease, and there's a reason for that. Nephropathy is something that we've kind of extrapolated from type 1 diabetes. And there is this paradigm that, proteinuria always precedes decline in GFR, which is not the case that we are now seeing in type 2 diabetes. What we are now seeing in type 2 diabetes is that you can have the classic proteinuric or albuminuric kidney disease, but you also have this subset of non-albuminuric kidney disease. So you're now defining diabetic kidney disease even without albuminuria. And we actually have done biopsies in these patients, and you find that, they do have some of the classical lesions of diabetic nephropathy, but they also have tubulointerstitial changes. And sometimes the tubulointerstitial disease is more predictive of how your GFR will decline. Having said that, if you have a patient with albuminuria, which is positive on repeated checking, or you have somebody with reduced GFR, which is not attributable to any other cause, then you really are trying to protect their decline in GFR over the period of, next few years to decades, and try to prevent them from going into ESKD. But before we do that, if there is one thing that, as a nephrologist, I would like to, if I'm discussing with other specialties, the most weird thing for us is that when we hear the term normal creatinine, because all these equations of GFR that we have are basically calculations from, creatinine values. And the eGFR equations that we have, at least the most famous ones that we have, the MDRD one, basically they are derived largely from a subset of non-diabetic subjects. And it was a study on, the role of protein in diet and kidney disease. And then that was not a very positive study. And then they got these equations out of the study, which kind of, in at least a largely non-diabetic set of people, correlates well with iothalamate clearance. Whether or not these equations really tell us what is going on in terms of GFR, the evidence is not very strong for that. So, and the other thing is the nature of creatinine itself. When a person travels within a range of normal creatinine from, let's say, a creatinine of 0.6 to a creatinine of 1.1, essentially you've lost 45% of your GFR. So even within the so-called normal range of creatinine, there is a huge amount of kidney damage that can happen, and does happen, because these are the patients you see when they come to you with creatinine of 1.2, 1.3 and all. So the question always is, how do you measure GFR? The easiest thing, of course, is what is available, which is our CKD EPI or MDRD equations. But there is a case to be made for using another marker like cystatin C, and we now have equations that combine both, which probably give you a better estimate of GFR than just MDRD or CKD EPI. And keep in mind that CKD EPI and MDRD GFR, they are not very good at measuring GFR above 60. The errors are much more when the GFR is above 60. So that's one thing. The other thing is that even in terms of microalbuminuria, in the last few years, the terminology has changed. We no longer say microalbuminuria, we say moderately increased albuminuria. We don't say macroalbuminuria now, we say severely increased albuminuria. We now have, the basic tenets of treatment are the same, intensive glucose control, intensive hypertension control, take care of cardiovascular risk factors, treat obesity. One more thing is to prevent episodes of AKI, because these patients are a unique subset where an episode of AKI, it could be gastroenteritis, it could be the use of NSAIDs, an episode of pyelonephritis. A diabetic patient with an episode of AKI can straight away land into CKD4. And we've seen this happen. So, so this is how I would broadly approach these patients with reduced GFR and proteinuria. Of course, we now have this wonderful gamut of drugs of, what you can use to treat albuminuria and all that. So obviously, if you have albuminuria, you would be using, especially if the BP is high, you would be using ACE inhibitors or ARBs. This patient is already on empagliflozin, which is wonderful. If despite, using maximum doses of ACE inhibitors or ARBs, along with SGLT2, if the proteinuria is still not controlled, then we now have, data from Figaro and Fidelio that Finrenone is really good, because all said and done, diabetes is an inflammatory disease, CKD is an inflammatory disease, and these drugs do target those pathways without much risk of hyperkalemia. If this patient is not hypertensive, I would be on the watch out for hypertension in this patient, because the way because diabetes is often a cause of hypertension. Although hypertension and diabetes do coexist, but quite often we see that hypertension comes after diabetes in a lot of type 2 diabetics. And of course, the reason is the classical hyperglycemia leading to increased sodium reabsorption, leading to decreased sodium delivery to the macula densa, and then that triggers the afferent arteriole into dilating, and then again that activates the renin-angiotensin system, hyperfiltration, all these things. So I would be kind of on the watch out for hypertension. If somebody has reduced GFR and established albuminuria, I'd probably be screening them around once in 3 months. If they are, let's say, in stage 2, probably I'd go up to around once in 6 months. But once in 3 months for somebody who is up to stage 3, stage 4, because that is the time when you can actually do a lot of good. There is not much you can do once they are in stage 4 or stage 5. And coming to the newer drugs, I don't know if this patient has diabetic gastroparesis. If this patient has diabetic gastroparesis, I would not be, and suppose this patient was obese, I would be wary of using, the GLP-1 agonists. But yeah, management of obesity would be a big part of how I would treat, type 2 diabetes. Yeah, I hope that answered your question.
Thank you, Rajiv, sir. That was quite comprehensive. And I think up to the point I was actually thinking of asking you the role of ACE inhibitors, but that you have already answered. We'll go back to Vrinda. Vrinda, if you could, we have covered ophthalmology and nephrology part. Please walk us through other aspects of diabetes care.
So I also would recommend this patient get a dental examination. So again, dental examination is something that I routinely recommend to all newly diagnosed type 2 diabetic patients, as well as type 1 patients. This can be done annually if they don't have any other concerns. And this is essentially because patients with diabetes have been known to have, a higher likelihood of oral health issues like, more cavities and the infection of the gum disease and the whole periodontal area, the bones, the supporting structure of the teeth. So keeping that in mind, I usually would recommend them to see a dentist at this point of time too.
And Vrinda, is it a one-time thing, or do you think they need to be seen? Because typically what we say is we need to see a dentist once a year for dental hygiene. Now
Right.
we know that it typically does not happen. I don't know of anybody, at least in my circle, and I myself don't go and visit dentist once a year. But what is the recommendation for diabetic patients?
So the recommendation outlined in the guidelines is that they should be seeing a dentist at least once a year. Now, the frequency could be defined based on the initial assessment, to every 6 months as well. But the routine recommendation that I have is that at least once a year, go see your dentist.
We have Dr. Prasad here. Dr. Prasad is a senior dentist at KIMS Hospital in Secunderabad. Dr. Prasad, this is a 55-year-old female who is diabetic for about 7 years that we are discussing. Could you please walk us through what kind of role you play in taking care of such patients who come into you asymptomatic? They just came because their endocrinologist asked them to go and see a dental specialist. Dr. Prasad, please unmute yourself and you can share your thoughts.
Yeah, Mr. Anoop.
Yes,
Hello.
sir, please go ahead.
Yes,
sir,
first of all, thanks a lot for giving me the opportunity for sharing such a very good views regarding the diabetes and dental care. Today, we'll discuss just a guide to the healthy mouth regarding the diabetes patients. Normally, what will happen, whether you have irrespective of diabetic type 1 or type 2, we have when the blood sugar levels are increased, we face a lot of problems, either tooth decays, early gum diseases, periodontal diseases. Most of the people don't have any awareness regarding the health effects of dental when it is in the diabetic patient. Normally, it's a vice versa. when the sugar level has been raised, what will happen? No, the normal, we have a lot of microbia in our oral cavity. What will happen? It has an interaction with the sugars and starches. It forms a biofilm called as a plaque. When the plaque retains in that area, what will happen? It immediately releases some or other acids which destroy the enamel and causing a decay. That is more prone for the diabetic patients. That is the first thing. Second thing, if that film got retained, what will happen? It turns into the calculus where it become a major area for the bacteria to be in, and it damages a lot to the periodontium. Periodontium means it is surrounding the teeth. Next, what will happen? Once the tartar got this thing, it got irritated to the gingiva, and the gingivitis will start. Once the gingivitis will start, if you neglect that one, it leads to the periodontal diseases and loosening of teeth. Most of the diabetic patients, once they enter into my clinic, immediately after seeing the total generalized mobility of the teeth, I suspect that they have some diabetic problem, and I'll ask them to just went through a checkup for the diabetes and all that. The major thing is the tooth decay, gum diseases, advanced diseases, thrush, and dry mouth. These are all the symptoms. And what we have to do regarding that, proper dental care is the major thing. Make a commitment to manage your diabetes. That is the primary thing. Secondary thing, brush your teeth at least twice a day. Brush in the morning, at night, and ideally after meals and snacks. Use a soft bristle toothbrush and toothpaste that contains fluoride. Avoid vigorous or harsh scrubbing. Next one is floss your teeth at least once a day. It reduces a lot of food, where all the food which is going to impact it in that area, it gives a lot of relief for that one. And for next one is schedule regular dental visits. Visit your dentist at least twice a year. For a normal person, we used to refer once in a year, but for the diabetic people, twice a year, because the immunity against the infection will reduce for diabetic. So the action of bacteria will be more in the diabetic patients when compared with the normal patients. Make sure your dentist should know you that you have a diabetes. All the diabetic patients should inform to the dental surgeon whether they are diabetic. Look for early signs of gum diseases. Report any signs of gum disease, whether it is a redness or bleeding from gums when you are brushing, or is there any swelling or color change. Normal, the gingiva is a pale pink. It becomes into the red and boggy gingiva. Apart from that, see the mobility of the teeth. If the teeth is more mobile, you have to visit the dental surgeon. And foremost is halitosis. Halitosis also will be increased for a diabetic patient when compared to the normal patients. And if the patients have a dryness of mouth, then obviously the thrush will act in that area, and dryness again leads to the halitosis, decay, and periodontitis. And the final and foremost thing is don't smoke. Smoke increases the risk of serious diabetic complications, including gum disease and ultimately loss of your teeth. Managing diabetes is a lifelong commitment, and that includes proper dental care. Your efforts will be rewarded with a lifetime of healthy teeth and gums. Hello, Anoop?
Yes, sir.
Yeah, is it audible?
Yes, sir. You were audible and you were crisp and clear.
Yeah, thank you.
Thank you, Dr. Prasad, for that assessment about dental care in diabetes. Brinda, take us forward. We discussed about the dental care. What next for diabetic patients?
So Anoop, very important is to assess for the risk factors for coronary artery disease, cardiovascular disease. So I will definitely talk about measuring blood pressure, cholesterol levels. Ask about smoking history. About their family history, calculate their height, weight, and BMI. So it's very important, that we address all of these risk factors with the patient. And, I do talk to them that eventually, it's the bigger complications with uncontrolled diabetes and risk factors that we're talking about. So all these assessments are, essential at the very first visit with the physician at the time of diagnosis, what I mean to say. And based on the risk factor profile, we'll address each one of them individually and then talk about risk factor modification, lifestyle, medications. Routinely, I do have a good group of cardiologists here. We do not usually recommend sending everybody with asymptomatic state for, stress testing for cardiovascular disease, but assessment of risk factors is what I actually pay attention to.
So, yeah, go ahead, Brinda, sorry.
And I meant to say that even for patients with type 1 diabetes, measurement of blood pressure, cholesterols, paying attention to weight, all of these things, smoking history is very, very important to elicit, even at the first visit, with the physician.
So we'll proceed for the cardiovascular assessment. My co-host Praneeth probably can give his input. Praneeth, if this patient was to come to you referred from endocrinologist about cardiovascular risk assessment, she's asymptomatic, 55 female. Walk us through how do you take care of this patient?
Yeah, so for a diabetes, it is considered to be a risk marker for atherosclerotic cardiovascular diseases, meaning we discussed about microvascular complication. We are talking about macrovascular complication, which is coronary artery disease, peripheral artery disease, and cerebrovascular accident. And we have these risk factors, and diabetes is considered to be one of the important risk factors after hypertension and age. Now, because she is 50 plus female, presumably postmenopausal with a history of diabetes and hypertension, I would consider her to be having risk factors. I would try to see whether she already has any established coronary artery disease and peripheral artery disease, if needed, equally cerebrovascular risk for CVA, that is any carotid artery disease. So I would try to ask her symptoms about her physical activity, and does she have any exertional symptoms of dyspnea, any pain, any limb claudication, and equally I try to inquire into symptoms of any symptoms suggestive of any transient ischemic attacks, etc. If there is an established signs and symptoms suggestive of any coronary artery disease, I would try to investigate further to establish further. Or else I would kind of stop at this point of time. You said she's asymptomatic. I believe she's only at risk and she does not have an established coronary artery disease. Now, moving forward, for the investigations point of view, a basic ECG and echo is something that I would look into it. And if they are fine, I would be okay. Diabetes can also lead to not only coronary artery disease, sometimes myocardial dysfunction. So I would want to look at echo and an ECG to see whether she has any evidence of any myocardial damage or any MI silently, because we know diabetic patients can equally have a silent MI. For peripheral artery disease, I would try to look for peripheral pulses and try to see any radial or radiofemoral delay as a bedside investigation. And if available, I would ask for an ankle brachial index to look at peripheral artery disease. I would look into any presence of carotid bruit to try to see, and I have a low threshold to ask for carotid Doppler to look for carotid artery stenosis. So this is to establish about the three aspects of coronary, peripheral artery disease, and carotid artery disease. And for treatment point of view, in addition to strict control of diabetes, which the endo colleague is managing, in addition to that, I will have a very low threshold to put the patient on statins. Now, whether the patient should deserve the statin or not will be the question. The presence of diabetes itself in a postmenopausal woman, I would tend to put this patient on statin. Her LDL cholesterol is 122. I would try to target it less than 70 as a primary prevention of atherosclerotic cardiovascular diseases. Regarding antiplatelet, probably I will wait on it because she is young. Unless there is any other indication for me to give, I would be waiting to give an antiplatelet, but statin definitely yes. In addition to other drugs for control of hypertension and diabetes. So this is how I would probably approach this case.
Praneeth, quick question for you. Is there any diabetes patient on whom you will not give statin?
Almost no. For almost every patient, I would be putting a statin. The intensity may vary, but almost every diabetic patient will receive a statin unless there is any strong reason for me not to give.
And when you start statin, do you have a differentiation in terms of low dose versus high dose?
So preferably, I would try to gauge this based on the lipid profile. If the patient has a lipid profile, if I advise and they get it done, I would try to titrate the dose of statin to target the LDL. But if I do not have and I have to make an empirical, I would at least start with a moderate intensity statin to begin with and then titrate accordingly.
What if patients like these have a CT calcium score of 0?
Still, even if their calcium score is 0, I would still consider them to be having a risk of ASCVD. Postmenopausal women, for me, is considered to be having a risk. So I would be tempted, or I have a low threshold to give them on statin, even if their calcium score is low.
Thank you, Praneeth. Vrinda, we come back to you. We discussed the cardiovascular aspect of it. Anything that we are missing that we need to discuss?
Patients with diabetes should also undergo a comprehensive foot examination for assessment of peripheral neuropathy. Essentially, a newly diagnosed patient with type 2 diabetes, I would ask them to take off their shoes, look at their feet. Starts with just a good visual inspection, look for any deformities, check the gait, skin color, toenails for like fungal infection and all, check for any ulcers, calluses. And then, I would proceed with, checking for any loss of protective sensations like, the vibration sense, the pressure sense. So for that, we could utilize, the most commonly what I utilize is a 10-gram monofilament. And there are the pressure points is where you actually touch it and ask for the patient whether they can feel it or not. And then, tuning fork examination for vibration sense also can be utilized, put it on the bony prominence on the great toe, and then ask for the patient if they can actually sense the vibration and ask them when it stops. These patients then assess for like pedal pulses, check for reflexes. If there is a concern for decreased pedal pulses, I may consider getting ABIs for these patients. Usually these should be done like foot examination, visual inspection, like a brief, quick examination would be warranted. Like every time a patient visits you, a lot of times patients, don't even know with loss of sensation that they may be, having a small blister here and there or an ulceration. But a comprehensive examination could be taken care of essentially annually for most of the diabetic patients.
And Vrinda, what happens? So you check for monofilament test. Let's say you find some aberrancy. I'm guessing they are not able to feel it symmetrically or whatnot. If you find some aberrancy with monofilament, what is your next step? Do you send them to neurologist? What do you do?
So we do, it all starts with like, the ABCs, like, talk about glycemic control, good foot care, protective, footwear, and then medications as needed. So we do have medications approved for diabetic neuropathy that can be utilized, a lot of times based on the severity of the patient complaints, I may actually refer them to a neurologist.
So we do have neurologist in our attendance. Dr. Praveen is a neurologist at KIMS Hospital, and we both work together for a lot of our patients. Dr. Praveen, we are talking about a 55-year-old female who has diabetes for about 7 years, who saw Vrinda, and Vrinda thinks that there is some sensation difference on her monofilament examination. If this patient was to come to you, how are you going to proceed with these kind of patients who don't have any other overt symptoms? Dr. Praveen, if you could please unmute yourself and share your thoughts.
Yeah, good evening, everybody. Sorry for joining late. I was in one more program, therefore sorry. First of all, as we all know, as the time passes, especially in type 2 diabetes, most of them will be having a neuropathy. Therefore, whenever a patient comes with a symptom, because normally when they will have the symptom, they reach a neurologist. Now, what I try to see is that whether it's simple diabetic sensory neuropathy or not. If it is a simple diabetic sensory neuropathy, only the light touch has gone, but the joint position is preserved, vibration is normal, ankle jerk is okay. I don't do much. I suggest only to have a good glycemic control. I take it a point to teach about the foot care. That's it. But when there is a suggestion that there is an involvement of large fiber, vibration going down, and there is ankle jerks coming down, or asymmetry there, I make it a point to definitely investigate. Common things, as we all know, we definitely check for a vitamin B12, a thyroid profile, and definitely a good amount of look for glycemic control. Here, one caveat I would like to add is that we have subset of patients who do not diabetic, pre-diabetic, who will be having a bad sugar control, normal sugars, but a sensory neuropathy. In those patients also, nowadays, I make it a point to look for any evidence of pre-diabetes, and I educate them about the symptoms and how to look forward and prevent the diabetes from progression.
And sir, if you could give a brief overview on the pharmacotherapy for this kind of neuropathy, or any other lifestyle measures that you can suggest them to prevent injuries or whatnot.
True. First and the foremost is that there are no preventive medications for diabetic neuropathy. Much water has passed through the bridge. Some talk about the aldose reductase inhibitors, some talk about some supplements, but till now there is no medicine to prevent neuropathy apart from a good glycemic control. And definitely we have lots of medicine which take care of the symptoms, especially the positive symptoms, paresthesias. And as we all know, what is it? They are the calcium ligand binders, such as gabapentin, pregabalin. This is what we commonly use. And of late, what we see is that pregabalin, we Indians don't tolerate. Even with the medium, small dosage, most of them complain about giddiness. In those patients, I find gabapentin to be very good. Duloxetine is one more tablet, which is used sparingly, but in patients who has some psychiatric issues, that works well. Most of it, but when there's just a sensory neuropathy, I try to educate the patient, the attendants, and look for any deficiencies. And definitely with the advent of so many creams, now we have lidocaine cream, we have a combination of gabapentin and lidocaine. I make it a point to suggest these to each of my patients. Most of them like it, some of them don't. After that, you would be able to tolerate, and you won't need any other medication. The only suggestion that the medications are not needed, most of the patients use topical ointments. That I find it's very helpful in my managing the day-to-day practice.
Thank you, Dr. Praveen. We'll move on.
Yeah, I'd like to add a small point, if I may.
Yes, go ahead.
Yeah, one of my personal experiences is that people do present with worsening of neuropathy, especially when they've had a rapid fall in their HbA1c. And we do notice this with some of the newer drugs, especially, the GLP-1 agonists. But also, when somebody comes to you with sugars of 400, 500, and you put them on a very high dose of insulin, and they come back 2 weeks later and, they have burning in their feet. And I think the term is insulin neuritis or something like that. But quite often, at least at my end, what I notice is that it's not just established diabetic neuropathy, but also a recent rapid improvement in glycemic control that causes this. I would like to know your thoughts on it, sir, Dr. Praveen.
Yes, I totally agree. Initially, it was called as insulin neuritis also. When we introduce insulin or there is a rapid control, that definitely causes painful neuropathy. Many times it causes a lumbosacral plexopathy that becomes unbearable. Patient, apart from the pain, cannot walk also. That therefore, I always look into it when there is a patient who has come with sudden worsening. What has happened? Has he pushed for a good sugar control? And that's it. But the problem is that these patients also, we don't have any other management apart from the medications which we use day in and day out. Yes, in some lay cases, they have suggested using immunomodulation with IVIG, but I have only used for about patient or two who had very bad lumbosacral plexopathy after a rapid correction of glucose. Mostly, I manage it symptomatically.
Thank you.
Thank you, Dr. Praveen. We will move on. And before I open the session for discussion, Brinda, any last points that we are missing before I ask rest of my attendees for their opinion? And my apologies to the attendees. We are probably going to exceed our dedicated time, maybe 10 more minutes. So if you could hang around for that time period so we can have a little bit of discussion, a follow-up discussion on that. So Brinda, final comments from your side before I open the discussion.
One quick reminder that patients with type 1 diabetes, because of the autoimmune nature of the condition, should be screened for thyroid disease, at the time of diagnosis, and then annually afterwards. That's what I do. Also with the tissue transglutaminase IgA, the antibody. We should definitely, she's 55 years of age for this case, we should talk about the routine cancer screenings, because patients with diabetes are usually at a higher risk of developing morbidity and mortality from cancer. So we should address that also. And then vaccinations, lastly. Talking about pneumovax, talking about, influenza vaccination, I think that would be my recommendation for this patient at her first visit with me.
Thank you, Brinda. With this, I open the discussion to my attendees, and I will start with Dr. Satyanarayana. Dr. Satyanarayana, I know you have a very keen interest in lifestyle diseases, particularly diabetes. If you could just share your thoughts about how we take care of these patients. And please be reminded, we are not talking about sugar control this time. This we will address in a different session altogether. Dr. Satyanarayana.
Yeah, thank you very much, Dr. Anoop and Dr. Somaraju, and asking for my opinion. I'm sure diabetes means controlling the sugar is a suboptimal way of treating the diabetes. The pathophysiology, if you look at the type 1 diabetes or a type 2 diabetes or the other rare varieties like Ladon and the Modi, the situation here, what we have to understand is the background mechanism. Once if you understand this one, type 1 diabetes is a lack of insulin produced by the beta cells of the pancreas. Whereas type 2 diabetes is the result of hyperinsulinemia. And also the so-called the blood sugar paradigm, by the time we recognize to label somebody as a diabetic, the insulin resistance has developed, and also particularly microvascular complications, what we discussed all the time, like retinopathy, nephropathy, neuropathy, and angiopathy, etc., etc. If you look at all the common denominator for this one is the vascular endothelium. And that is caused by the insulin excess, insulin resistance. So the diabetes, even though looks like many organs are involved, basically it is a reflection of the vascular disease. If you identify anybody don't bother about blood sugars at all. A simple science like skin tags, acanthosis nigricans, which tell you the insulin resistance. And if you start monitoring plasma insulin and calculate the HOMO-IR, these are the better markers than estimating HbA1c or even blood sugar. When once somebody is having higher amount of HOMO-IR, and particularly if they got a dyslipidemia, don't wait for LDL to increase. If the triglycerides and HDL ratio, if it is more than 2, that means he is at risk of diabetes. Yes, somebody told, if somebody has got a cardiovascular disease and if he doesn't have a diabetes, if somebody says it is undetected diabetes. So cardiovascular disease cannot exist without diabetes. It is so synonymous. So in view of all these things, what I normally do for all these kind of patients when they come to me, I blame all the time insulin resistance if it is a type 2 diabetes. If it is a type 1, I go for C-peptide and also the measurement of the insulin levels and HOMO-IR. So we are not discussing about type 1. Type 2, I take all the measures to reduce the insulin resistance and improve the insulin sensitivity. Once the insulin sensitivity is improved, either pharmacotherapy or non-pharmacological therapy, you can improve all the symptoms and also you can prevent the progress of the retinopathy, angiopathy, nephropathy, and all other things which are commonly associated with advanced glycemic end products. This is the result of the advanced glycemic end products. Particularly, this is a result of the mitochondrial dysfunction. If you understand mitochondria and correct the mitochondrial dysfunction, probably we can correct all these things. Any drug that increases the insulin production, including insulin, worsens the type 2 diabetes, particularly sulfonylureas. Whereas the metformin and other drugs like SGLP inhibitors or GLP inhibitors, which does not increase the insulin production, they increase the insulin sensitivity. That's why they're cardioprotective also. Of late, so much of literature we are seeing SGLP inhibitors and in the added benefit to the cardiovascular disease. So in this way, what in a nutshell I want to say is type 2 diabetes is not lack of insulin. It is the excess production of the insulin and insulin resistance. If you can take care of insulin resistance and if you improve the insulin sensitivity, all the pathophysiology, what we discussed, the end organ failures, we can prevent it. Even if they develop some sort of advanced stage in a retinopathy or cardiovascular disease or nephropathy, we can still prevent at the stage and we can prevent the progress. So this is what I feel and I do like this. And personally, I improved my insulin dependent diabetes. 80 units I used to take morning, 80 units in the evening, and also another 3 oral anti-diabetics plus anti-hypertensive drugs. And I got a remission from the diabetes and I'm not taking any kind of insulin or other drugs at present. So particularly if you are interested, Roy Taylor from UK, like a twin cycle theory, or if you are interested, a nephrologist called Jason Fung from Ontario, Canada, they have written a diabetic code. If you go through these things, probably you will understand more how to manage the diabetes. Thank you very much for giving me the time.
Thank you so much, sir. I will invite Shankar sir to give his opinion. Shankar sir, you have heard all the discussion which has been going on so far. Please let us know your thoughts and something that we have missed in our entire discussion.
Apart from the earlier, good evening to all. Earlier, we used to concentrate on only glycemic control. So glucocentric, our approach. But now, our approach is patient-centric. Just now, Dr. P.V. Satyanarayana sir already told, the approach is now patient-centric. So personalized medicine is there now. The glycemic control, we now the parameters are there like fasting blood sugar and the post-lunch or postprandial blood sugars. Fasting is 80 to 110 or 130, up to 130 also ADA allows. Then postprandial, it should be less than 180. Then HbA1c, it should be less than 7. Then now one more parameter has come into O, that is the TIR, the time in range. So there, at least 70% of the day, our blood sugar should be in time in range, that is 70 milligrams to 180 milligrams, to avoid diabetes related complications. That is regarding the only glycemic control, the blood sugars and the HbA1c and the TIR, that will be done by CGM, that is a continuous glucose monitoring system. So regarding the microvascular complications, we should concentrate only on the glucose control, especially a tight blood sugar control should be there to avoid these microvascular complications like retinopathy, nephropathy, and the neuropathy. But macrovascular complements, the complications like coronary artery disease and the cerebrovascular disease, peripheral artery disease, they are mostly related to multifactorial risks. So we should control the blood pressure, we should control the lipid levels, we should stop smoking, and we should control the obesity. So this is regarding the microvascular and the macrovascular complications, well narrated by different specialists. I'm very happy. Nothing is to add, but the only thing is I want to know from Dr. Rajiv how to differentiate whether it is a diabetic kidney disease or non-diabetic kidney disease.
That's a very good question, sir. So one of the first things we do is we also screen for retinopathy. In type 2 diabetes, the concordance between established, biopsy-proven diabetic nephropathy and retinopathy is around 60%. So, I mean, it's not as great as it is in type 1 diabetes, but definitely it is something. So first up, if you see somebody with type 2 diabetes and they have significant albuminuria and they don't have retinopathy, that somewhere starts some alarm bell ringing that, this probably is, you have to look for non-diabetic renal disease. But there is also the way diabetic nephropathy behaves. Diabetic nephropathy is a slowly progressive disease with a decline in GFR of around, somewhere between 2 to 3 ml per year. So if you see somebody with either a rapid decline in GFR or a sudden rapid increase in albuminuria, or their urine starts showing new things, like RBC CAS, or, they have either a sudden accelerated hypertension, or, all these features, or a systemic disease, which is probably of autoimmune nature. If you have all these clues, then you really start thinking about non-diabetic renal disease. But the basic idea is that diabetic nephropathy, diabetic kidney disease is a very slowly progressive disease. And anything that kind of disturbs that slope, which is a predictable slope, then you start thinking about non-diabetic renal disease.
Thank you.
Thank you so much, Shankar sir. I will move on and invite Dr. Vijay Reddy sir. Sir, I do read some of the comments that you have put it in the chat box. If you could just share your thoughts in addition to what we have discussed already about diabetes care. Vijay Reddy sir.
Good evening to all. Everybody already they have discussed everything. I want to assess only two things regarding that. There is no doubt that statin should be given irrespective of the lipid status between 42 to 75 years in primary prevention. That is number one. Number two is very low levels of lipoprotein A will lead to diabetes. That is also one of the established fact. The mechanism is still not known, but it is a very much established fact. These are the two things I want to highlight.
Thank you so much, Vijay sir. I'll invite Somaraju sir for his comments about today's discussion and anything that we missed. Somaraju sir.
Thank you, Anoop, Praneeth, and I think almost everything is covered, except to just point out one or two issues, namely in the evaluation of a patient with diabetes you're talking about, you must not miss out on physical activity and exercise, and also the food we eat is medicine, particularly in diabetes. So they not only the patient, but the whole family should be advised because they have a tendency for diabetes. So food or diet, physical activity and exercise. Physical activity and exercise are different things, as you know. I won't highlight it now. And also any patient in diabetes, particularly when they are on metformin long term, they are vegetarians particularly, B12 deficiency is particularly common. It's not only neuropathy it contributes, but also tendency for thrombosis in a cardiovascular high-risk patient. We see very young people coming with B12 deficiency and thrombosis and acute myocardial infarction and no other risk factors. So please keep that in mind. B12 should be estimated, and homocysteine plus B12 combination helps us to make the decisions. And also don't forget about diet, exercise, physical activity, and also whatever we advise the patient. Somebody said, Dr. Satyanarayana said, patient-centered, as somebody said. Today, patient-centered means if you don't find out the social determinants of health in the patient you are dealing with, you can't treat diabetes properly. Thank you.
Thank you so much, sir. Very relevant, the social determinants that often we as an end care provider, sometimes we find it disabled to address that, but I think it requires an active attempt for each one of us, at least to look into. If we can't change things that much, but at least we should look into. Education is a very important and simpler thing for doctors, because the lack of education is one of the determinant of poor health. So at least this is one thing that we can do. If anybody has got any questions or comments about today's discussion, we can take it for the next maybe 1 minute or so. I know we are exceeding our time today, but we had a very comprehensive discussion, so I thought it's worth extending the time. If there are no questions, then I'll ask Praneeth for today's closing remarks.
Yeah, so a comprehensive discussion. Diabetes having both macro and microvascular complications. So every diabetic patient should be evaluated for both of them. I think the attention goes with macrovascular complications, and microvascular complications are often missed, and the neuro, nephro, and retinopathy has been well covered by the respective specialists. And the forgotten part was the dental examination, which also has been well highlighted by our dental surgeon. So I think with the inputs which have been given and the discussion that we had, I believe it is the responsibility of every physician or a doctor who encounters a diabetic patient that these respected specialists need to be encountered at least once or as recommended, and thereby we can probably provide a more comprehensive care to this patient and not focusing only on sugars, where most of the attention is going to that particular aspect. I believe this should definitely change the practice patterns, and which will equally help the patients. Thank you, Anoop.
Thank you, Praneeth, and my sincere thanks to all the guests who made it to the discussion today. I thank doctors, namely Brinda, Rajiv sir, Prasad sir, Praveen sir, and Prithvivyas sir for their thought process, and everybody else who contributed to today's discussion. As you all know that we have changed our timing. Earlier we were doing it 7 p.m., but now we are doing it at 8 p.m. to accommodate the requirements. And we are trying to include more subspecialist topics, or I would say a little bit of expertise topics, these days, and we are trying to get at least 1 or 2 experts in today's in all of the discussion. So we'll be back next Wednesday. I have already shared the schedule of the topics that we are going to cover this month and next month, which is there on the WhatsApp huddle group. If you have not joined yet, I request you to do so. The links are there in the invite. I'll see you next Wednesday at 8 o'clock with a new topic. Till then, good night, and thank you all. Have a good week ahead.
Good night, all.